once we have the initial workup in progress, well, right away we do notify Randy, and they start looking, and they have a whole protocol to start looking for a donor. We have HLA typed our most recent patient, and now I would like to invite Randy up to tell how we do a transplant evaluation.
Thank you. I'm sorry, but that's not what I'm going to talk about. I did want to tell a story, though, about one of our patients that we sent to the mainline, went to Hopkins, because the mother's family moved to Baltimore for a job transfer, and they had thought that it might be easier for them actually to go to the mainland so that the mother's mother could watch the other kids. So they just packed up the whole family to get an autologous transplant for neuroblastoma. They came back to the clinic, so I was asking the mom, so, oh, how was the mainland? And she goes, oh, you know the funny thing? First time I've ever been someplace where you just drive and you don't hit water. It's a different thing for our patients to leave, I have to say. So I just wanted to tell you a little bit about our program. We're not going to talk so much about the workup in the sense that Ted covered some of that. But just to show you that the vast majority of the patients we see here come from Kapiolani, some from Tripler, and then we do receive referrals from Guam, Saipan, American Samoa, the Marshall Islands. And we have a tiny transplant program here. There's actually not even enough children in the state of Hawaii to justify a children's hospital, actually. But just looking over the last 10 years, we've had a range of cases per year, 2 to 8, average of 5, a mix of autologous and related allogeneic transplants that include 4 haplos done with either reduced intensity or non-myeloablative with post-transplant cyclophosphamide, and then a couple cord blood transplants. Okay. All right, and as you'd expect, actually, most of our transplants have been for malignancies, neuroblastoma, leukemias, lymphomas, with a smattering of some non-malignant severe aplastic anemias, PNH, Fanconi's. And as you can guess from what Marion said, we actually haven't done an immunodeficiency patient here, so we're very excited to at least get the crack at one that's not super sick already. So here's the program components. First of all, of course, Kapiolani. And I have to say that in the past, we used to depend on the adult transplant program for everything. And then over the past 3 years or so since the adult program closed, and now we're the only transplant program in the state of Hawaii, Kapiolani's had to take on all the rest of the stuff. So we don't have a real deep program, but we have a real wide program. And that includes not just the transplant center, which is the NMDP affiliate status, but we've also had to develop the collection center for bone marrow collection, an apheresis center, which has included getting the apheresis machines, training the staff, and doing these procedures. But we've been successful in accumulating these components of the program that we had in the past depended on the adult hospital to provide us. That we also have had to take on the laboratory part of this too, because in the past it had been run by a private company called Clinical Labs, and they signaled that this wasn't really in their business plan anymore. So in order for us to continue doing transplants, the Hawaii Cord Blood Bank actually took over the operations of this stem cell processing lab. We do also have a NMDP-affiliated bone marrow donor registry in the state of Hawaii, and approximately 1 out of every 7 Asian Pacific Islander donor in the country's registry comes from Hawaii. Hawaii has the highest percentage of its population that are part of this national registry. And back in the late 90s, in fact, around this transplant patient named Alana Dung. Over 35,000 Hawaii residents joined the National Registry in the span of about a month, actually changed the shape of the matching curves for Asian Pacific Islanders. And we have a cord blood bank, too, that operates at all 5 of the birthing hospitals on Oahu, plus Maui Memorial Medical Center, which Maui County, by the way, is the most ethnically diverse county in the United States, because it includes, of course, Maui, Lanai, and Molokai. And the units are listed with the NMDP through collaboration with Puget Sound. Over 90% of the units we collect come from Asian Pacific Islanders or, of course, multi-race donors. So here's our challenges. The first is what Marion alluded to, that travel to the mainland is really difficult for our families because they don't have the support. It costs a lot. And you know what? They don't serve Portuguese sausage at the McDonald's on the mainland. Yeah. And on our side, you know, we have a lot of components to the program that have to be juggled. And unlike a big center like UCLA that pretty much has all of these self-contained within the institution, Kapiolani has to sort of partner with a whole bunch of other pieces. And then, of course, there's the geographic barriers. Here's a nice map that shows how isolated we are. We're the world's most isolated population center. And the problems are that there's too much water and there's too few people. So here's a graphic of where our referral area comes from. Of course, there's the state of Hawaii. And here's the areas that we're responsible for: Guam, the Federated States of Micronesia, American Samoa. And I think the thing to point out here is the distance that these places cover is more separated than the whole country. So as part of the geographical challenge that we have is also access. And it's access in a number of areas. It's access to clinical trials, practice guidelines, rapid turnaround for molecular diagnostics. Many of the labs are sent out to the mainland. There's a 3 to 5 day turnaround time depending on when you hit the shipment. Specialized equipment. For us to have photophoresis, for example, is a work in progress. We're working on it, but that's a limitation. And so that we really do appreciate quite a lot this opportunity to partner with you guys at UCLA. I'm so grateful for it. And I think one hopeful thing I can say is that given the role of Kapiolani as sort of the tertiary care center for the Pacific Basin, that this may be a nice template for the expansion of this kind of collaboration into other aspects of pediatrics and perhaps even OBGYN. So as I mentioned, that's the big opportunity now, the SCID newborn screening project that we have with the state and UCLA. It may be that therapy for hemoglobinopathies, I think we have 1 sickler, maybe 2 sicklers here, but there's thalassemics, and that may be another avenue of transplant therapy that we can start developing more. The apheresis, plasma exchange. And then the Department of Defense donors, that's an interesting thing too. Right now the Department of Defense, for all the collections, they send their, well, I guess they have airplanes. So they send their donors to the mainland. Even if they come from Asia, they fly them all the way to Washington, D.C. And so they're obviously interested in a more cost-effective location to do this stuff. And then I think because the cord blood bank now is running the cellular therapy lab, we're hoping to provide more service that would facilitate the transplant program. And so since I realized that I was going to be the last person, I wanted to keep it short, and I'm going to end here. So thank you for your attention.